conducting research. Sorry about that. Conducting research on visual impairment and mobility disability. Her work uses data-driven approaches to transform societal views of disability, an approach that has been summarized as, quote, shifting the paradigm from living with a disability to thriving with a disability. Recently, she has spearheaded a number of national advocacy efforts working with advocates, civil rights leaders, and congressional representatives to, among other things, one, urge the NIH to designate people with disabilities as health disparity population, which they formally did, to successfully urging the Census Bureau to halt certain changes they proposed making to their disability questions in the American Community Survey. Among her many other accomplishments, she was named a health equity champion by the Centers for Disease Control and Prevention, serves on the US Census Bureau Scientific Advisory Committee, and is an elected member of the National Academy of Social Insurance. So I could go on, it's a lot, but I don't want to take away from time with her. So without further ado, please join me in welcoming Dr. Bonnie Swenor.
All right, thank you so much for that very kind introduction. It's always good to speak to my alma mater, home department, the Epi department. Do I need to fix anything on that? Sorry, do I need to do that? I don't see it. Sorry. Let me make sure I don't do it. Oh, okay.
Yeah, we're fine.
Sorry. Yeah, so first of all, I just want to say today is complicated, right? The things I'm going to be talking about probably landed a little bit differently even just a couple weeks ago than they do now. And I think, I'll just say that up front. It's a complicated time. And, I'm going to use words like equity that are increasingly complicated. And I think it's just, I think we need to just talk about it. And so that's my first slide, which is just addressing the elephant in the room, right? It's a picture of an elephant. And that all of this work is changing and shifting in ways I don't even know. And I gave a very similar talk 2 weeks ago at a different institution. And, I've constantly been updating and making changes and thinking about how to alter this presentation. And I'm sure I'll continue to do so. But a lot of unknowns. I just want to say that up front. And so really happy to have this conversation and hopefully continue to. So the other point I want to make before I get into what I'm really going to talk about is I think now more than ever, it's important to think about the bidirectional relationship between data and society. I don't think we always think about this enough, particularly in places like grad school, where by and large, and rightfully so, our goal is to learn methods and to gain experience and to get out into the real world and use them. But it is essential to understand that the analyses we do, the data we use, the way we interpret that data, the way that we share that data matters. And the data we use, the analysis we do, and the interpretation of that data is absolutely informed by societal views. And that's a theme that I think is going to come up a lot in what my presentation is today, and I think is a point of continued and elevated discussion, perhaps at this moment. And I hope that's a conversation point happening again and again in this department. All right, so let's talk about disability. And I want to first start by saying disability is not a bad word. And there's mounting research talking about just that concept. Historically, particularly in public health, we are taught that disability is something to prevent, something to eliminate, something to minimize. But that is not how the disability community views disability of themselves, right? And increasingly so, that is changing. And so, unfortunately, even in public health, we still aren't taught an alternative view of disability. And that shaped my own career. going through public health training here as a person with a disability, I have a visual disability. It was very challenging to learn about disability as something that is completely negative, an outcome to prevent and to reduce, when I myself am a person with a disability. So where does that leave me? Right? We're not going to invest time and resources into making sure people with disabilities thrive. And I think that's a problem. And that's a challenge that I think we need to interrogate and think carefully about, because this is common. Latest data from CDC, data I hope is still available, shows that 1 in 4 American adults has a disability. That's more than 70,000 people. And we know that's an underestimate. I'll talk about that in a minute. But what that means is that people with disabilities are a large majority, in fact, the biggest minority group, large minority, the biggest minority in the US and around the world. And then that also means that the ways in which we study, the ways in which we include people with disabilities, and the ways in which we interpret data about disabled people matters, because it matters for a significant portion of our population. And people with disabilities are part of all of our communities. That, I would say, is intersectionality, but I'm probably not supposed to say that right now. So it's also important to understand that the shifts in views of disability in society have far accelerated in the past 5-10 years, but research spaces, healthcare spaces, public health spaces have absolutely not kept pace. There is a massive disconnect between how people with disabilities and the disability community view themselves and how we are researching disability. So what I'm showing on this slide is to portray that change. So we've moved from a place of disability rights as a social movement to disability justice. Disability rights was a really important movement that brought us the Americans with Disabilities Act, which passed in 1990. And that was all about ensuring people with disabilities have the same rights as people without. Under question today, unfortunately. But disability justice is realizing that what we have learned time and time again is that when you give everyone the same thing, we don't all get to success. We don't all have the barriers removed that are in front of us. So disability justice is an official framework with 10 pillars that was developed by a group of Black, queer, disabled women who actually did not identify or see themselves in the disability rights movement, which was a largely predominant white disabled movement. Part of the disability justice movement is also about making sure there is a unity across the disability community. So often in research, we focus on people with vision disabilities or hearing disabilities or mobility disabilities. And I'm not saying we shouldn't do that. But so often in the work I've done and in feedback from study sections and in editors' remarks, there is a concept, there is no commonality across this very large community of people, which are very different. And that's not true. We're not all the same, but we do have some unique commonalities in the things we experience, the barriers we face. So disability justice can be summarized as a framework that understands that all bodies are unique and essential, and that all bodies have strengths and needs that must be met. That concept is a challenge in public health because in public health, there is an inherent hierarchy behind the concept of health that I don't think we spend enough time thinking about. So what I mean is, when we think about the goal of health, what does that mean? And so often that means that our historic view of disabled people, people with disabilities, is at the bottom, that's the opposite of health, right? So what does that mean for someone like me that has a disability? Does that mean I cannot be healthy? Does that mean that in moments of crisis with scarce resources during the time of COVID, that my life is less valuable and shouldn't get access to the same opportunities for care and vaccines as people without disabilities? Those were the kinds of questions that were front and center during the pandemic and honestly have always been there. And that is driven by the hierarchy that we assign to our construct and our concept of health, where people with disabilities are at the bottom, less valuable. The view is that there's less contribution to society for disabled people. And so they don't deserve the same resources, attention, research. And that's a problem because that flies in the face of work to advance health equity, which should be about eroding that hierarchy, but hasn't for so long. So this work thinking about health equity and disability is not new. It didn't start with my center or the work that I do. And in fact, Gloria Cron, who is a public health legend in the disability health equity space, who used to work at CDC, is now at Oregon, but now retired, wrote this landmark paper in 2015, and I'm showing some data from it that are elegant and simple at the same time, that really put a mark in changing a need to change the way we think about people with disabilities as a population that faces health disparities. And these data are simply just showing that people with disabilities, a higher prevalence, are smokers, don't engage in physical activity, cardiovascular disease, are obese, aren't receiving the medical care they need due to costs, and that women with disabilities, a lower prevalence, are up to date on mammograms and pap tests. Very common outcomes that we would look at as public health professionals, as epidemiologists, to think about if there's inequities in any sort of subgroup. But so often the view is, well, of course people with disabilities aren't engaging in physical activity. Why is that? Why haven't we challenged that? So my center has also done some work in this space, and we've looked at the social drivers of health, or social determinants of health. And we're not, again, the only ones to publish this, but this is some of our work showing an updated data that people with disabilities, a higher prevalence, have less than a high school education, have a low household income below $25,000 per year, and a higher percentage of people with disabilities are unemployed. All factors we know are contributors to the health status of our communities and our populations. Additionally, and this is principles of disability justice, thinking about a deeper look at the data and looking at through a lens of intersectionality. I know those concepts are being challenged right now, and looking across race, ethnicity, and I see it's fixed, but I apologize, the key is not there, and showing that the green bar and the purple bar are disabled people who are Black and Hispanic. And when you further stratify those data by race, ethnicity, you see the highest percentage of Black and Hispanic individuals with disabilities have less than a high school education, low income, and are unemployed. But so often when we're thinking about inequities and health inequities in certain groups, we're not thinking about the full picture. We're not thinking about people with disabilities in multiply marginalized groups, for example, or we're not thinking about disability in our efforts to advance racial equity. And that needs to change. A lot needs to change right now, but so this is a graphic from an animation from the CDC. And so I like this graphic because it portrays the concept of our pursuit of addressing health equity or health inequities is important, but really the goal should have been to design the world before the inequities existed, right? That really should be the goal. We shouldn't always be putting a Band-Aid on things and fixing what's broken. We should think about ways to design and build things so those inequities didn't happen in the first place. So this is a scene, animation of a library where the shelves are usually quite tall, and people who are wheelchair users and of shorter stature can't reach the top. And if we had brought those shelves closer to the ground where everyone could access them, that would be perhaps more equitable access to information, right? Information and data is always important. So building on that basis, thinking about the inequities that people with disabilities face and the fact that we haven't focused on this in public health, I was really motivated to start my center, which I started in 2019, the Disability Health Research Center. It's hard to believe it's been 5 years. And as Heather indicated, our tagline is shifting the paradigm from living with a disability to thriving with a disability. And what I'm showing on this slide is a picture I've shown a number of times in my talks, which is a set of escalators, steps in DC from a metro stop with a bright light at the top. And that's where that's the exact location where my own disability journey started. I have a retinal degenerative condition, and I had a rapid onset of vision loss on those exact escalator stairs months after I sent in my application here to the MPH program. And at the time, I pulled my application because I didn't think I could do it. I didn't know anyone else who was like me. I didn't know another blind researcher or public health professional. And I just assumed I couldn't because of that, right? The world had trained me and taught me to believe that. Ultimately, right, that's not the case. I'm here today. But it's been a very complicated and challenging journey as a professional, as an individual to get here, let alone the research. I know those concepts are getting challenged today, but it is essential to think about that. Who gets into these spaces and who is kept out? And our loss of opportunity about thinking about things differently when we do keep people out. And so those concepts really informed the strategic goals of the center, which we talk about as being science and justice-based together. So we're really focused on filling disability data gaps. There's so many gaps in data. We don't collect disability data in all the places that we should be. And because of that, we can't address the inequities that people with disabilities face. So we're really motivated as a center to try and do what we can with what we've got. Additionally, we have learned, as I just described, that part of our work and our mission has to be about training the next generation of disability researchers. That includes people with disabilities and people without. People who are doing research that aren't yet including people with disabilities and are open and interested in thinking about how to expand their work to that. And people with disabilities who want to be in public health and are facing real barriers in a variety of ways to achieving that. Additionally, and probably our most important goal is partnering with the disability community. We believe that everything we do must be in partnership and with the community, must be co-led by people with disabilities. And we also believe that our data don't belong to us. So we have a very important focus on not stopping at peer review publications. We make sure that we get our data and our information back to the disability community, and we're always working and thinking carefully about how we can improve that process, because that community needs the information that we're generating. And it's not going to be in the form of scientific jargon and in a peer-reviewed paper. That's extra work, and that's work that we're often not paid for or funded for, but we think it is absolutely essential. And so in this approach in the center, we have thought carefully about how to address the root causes of disability inequities so we can get to those root causes before those inequities start. And in thinking about that, there's really two reasons that we have disability inequities, two root issues, and that's ableism and inaccessibility. We have got to battle both of those at once, and we've learned that, to get to progress. So ableism, for those of you that's a new concept, this is a very simple definition, but ableism is rooted in the assumption that non-disabled people are the ideal. It's a simple definition. There's many definitions of ableism, and that's from Amanda Morris, who covers the disability beat in the Washington Post. She actually had a great article, I think this week, on the lack of ASL interpreters in federal jobs right now. Amanda Morris herself has a disability. But that concept that non-disabled people are the ideal, it's what we're taught. We don't question that, right? That's ableism, right? Ableism is a threat to health equity for all the reasons I was describing. The fact that in that concept, in that line of thinking, is the idea that people with disabilities are at the bottom of the pile when it comes to health. They're the opposite. We haven't challenged that concept in public health enough. And my colleague Lisa Izzoni, who is really a legend in this work of disability health equity as a professor at Harvard, has done some really remarkable work in trying to demonstrate and document this with data, and has conducted a quantitative survey of the views of practicing physicians about people with disabilities. And in this survey, she found that 82% of physicians reported that they believe people with significant disabilities have a worse quality of life than non-disabled people. Again, that's what we're taught, right? It's what qualities and dollies are built on, that construct. But many disabled people push back on that. They have an excellent quality of life. It's the barriers they face that hold them back. And it is the idea that non-disabled people have built those constructs and are making strong assumptions about the quality of our lives without including us in those decisions. Additionally, only 40% of physicians are very confident in their ability to provide the same quality of care to patients with disabilities as those without, less than half. And just 56.5% of physicians strongly agree that they would welcome patients with disabilities into their practices. That's illegal. Additionally, Lisa partnered with Tara Legoo, who used to be at Northwestern, has left academia, I'm afraid, and has done some great qualitative work to follow up on that survey to better understand the perceptions of physicians towards patients with disabilities. They got a lot of great attention, including being covered in the New York Times, obviously not paid by the Times. And this is a quote. Some doctors said their office scales could not accommodate wheelchairs, so they told patients to go to a supermarket, a grain elevator, a cattle processing plant, or a zoo to be waiting. This is coming directly from physicians themselves, of how they take care of patients who are wheelchair users. Telling someone to go to a zoo to get their weight, a metric so essential we captured every single healthcare encounter. That's ableism. It's unacceptable. But in addition to ableism, we have to think about accessibility, or the opposite, inaccessibility, the lack of accessibility. So often when people envision what that word means, and it's used in a lot of different ways, let me just say that. But in this setting, when we're talking about accessibility for people with disabilities, I don't just mean environmental accessibility, right, of physical spaces. Inaccessibility is barriers to information, to communication, to interactions, to services, to programs, to physical spaces like facilities and environments. Lots of opportunities, unfortunately, for things to not be accessible. The other concept of accessibility that's often forgotten is that to really be accessible, there has to be equivalent ease of use. And so what that means is that if it takes me 5 times as long to complete a task than someone without a disability, even though I can complete the task, there's not equivalent ease of use. It's not access. It's called a disability tax. And that's real, and unfortunately all around us. But the most important concept of accessibility that is often forgotten or not understood is that it is everybody's responsibility. Stella Young, who was an amazing Australian disability activist and comedian who's now passed, had a saying that no matter how much you stare at a flight of steps, they don't turn into a ramp. That is it exactly, right? No one individual, no wheelchair user can automatically make a flight of stairs into the ramp that they need. That would have taken many individuals to have committed to a more accessible and equitable world. This concept of the importance of accessibility in public health, and at my center, we actually think of accessibility as a driver of health. It's one of the social determinants of health that we don't think about, but we do. Really came to the forefront again during COVID. And so what I'm showing on this slide is snapshots of news headlines about how people who are blind or had low vision could not log into, get access about, information about, or register for COVID-19 vaccines early when the vaccines were being rolled out, when it was a scarce resource and we had to register. Those websites were not accessible. We're not compliant with federal guidelines. And this is something that was real. I experienced this myself. And my center had enormous outreach from the community, just imploring us to do something, to think carefully about what we could do as a center to try and make a difference in that. So at the time, we already had a dashboard tracking how people with disabilities were being, basically how COVID-19 was being allocated to people with disabilities across states. So in some states, people with disabilities were a priority group, and in other states they weren't. And so we were tracking this on a dashboard. And so what we decided is we were going to add a measure of how accessible state public health department information about COVID-19 vaccine was, and how accessible the state level registration websites were to get access to vaccine. So we partnered with our colleagues at WebAIM, which really is a leader in innovating on metrics of website accessibility, and our partner, University of Cincinnati, Kara Ayers, whose center at the time was called Center for Dignity in Healthcare for People with Disabilities. We had a little bit of funding from the American Association of People with Disabilities. And with an amazing group of over 20 committed students, we were scraping data every week from 50 states, DC, and 5 territories from the public health websites. And we shared our information on a publicly available dashboard or website of our own that we worked with WebAIM to make sure itself was meeting accessibility guidance. So what we would do is we would scour these websites on the accessibility dashboard and send them to WebAIM and create what we call an accessibility score. Lower number is like golf or an NIH grant score. Lower is better, lower number is better. It meant that there were fewer errors. And we also would have graphics in plain text to try and provide different ways that people can interact with the content. People can download the content in a variety of formats. We also put out maps showing how the scores differed across tertiles of those scores every week. And so we found there were place-based inequities in access to this information. And there was some shift in that over time, over our tracking. But it was just striking to me how often, as public health professionals, we don't think about people with disabilities facing place-based inequities. But this was an example of where that was clear. There were some states where there were horribly inaccessible websites and information, and individuals with certain disabilities in those states were really having a challenge to even get access to registering for vaccine. That's a correctable, but massive inequity. We got a call at one point from US Digital Services to help them in the design of vaccines.gov, which was an amazing conversation and opportunity. And so we worked with them on some concepts for that on their launch. And so on this slide I'm showing, which was the last run of the data, we included the capture of the vaccine.gov score, which they scored well. Obviously, we had worked with them though, so they knew what we were scoring on. So all of this experience and as we've built the center and continue to do the work, and to get back to how I started the conversation, has been a constant reminder of the power of data. I constantly think about that. Not a day goes by that I don't think about how powerful data are, perhaps maybe now more than ever. And with my colleague, Nick Reed, who used to be in the department, Lisa Meeks, who just moved to Chicago, we wrote a paper called "Who Counts Depends on Who is Counted." And that paper was all about how we weren't capturing metrics of disability in electronic health records in regular ways. So during the pandemic, we were not able to identify inequities in vaccine uptake, in mortality, in infection rates for people with disabilities in ways that we could look at that for other minority groups or across age groups. The best we could do was look in institutionalized settings, which is an incomplete picture of our disability community, right? Still to this day, we don't collect disability data in a standard or regular way in our electronic health records, and that's a problem. In fact, we don't routinely collect disability data anywhere. as a demographic component. And that has been a big pressure point since the COVID pandemic began, that my center has focused on, is this need to fill that data gap. The Affordable Care Act actually set out a precedent that disability is a demographic and is required to be collected as a demographic under all of the surveys and data collection components covered by that act. That has not been upheld, unfortunately. So a moment also came not too long ago, I think as Heather alluded to, where the Census Bureau was proposing to change the way disability was being measured in the ACS, the American Community Survey. Currently, there's 6 questions. They're not fantastic, I'll be frank. But the proposed change would have made them, in our minds, worse. The proposed change was to a set of questions that assessed slightly different components or measures of functioning, and asked those questions, the answer would be on a scale of severity of functioning. The problem there is, one, there was not engagement with the disability community, which was alarming. Most people in the community had no idea that this change was taking place on how they were being measured and assessed. Number 2, it could have potentially resulted in a 40% decrease in the estimates, national estimates of disability. There was confusion in how this was all tested and the evidence behind it. But ultimately, one of the biggest concepts that emerged from our pushback with the Census Bureau was that disability is still being viewed as an outcome and not a demographic group, as the Affordable Care Act outlined. And so a lot of the discourse we had with those fighting on different sides of this problem were really about this central issue, is how we are perceiving and conceptualizing disability. And it was a fascinating discourse in understanding that we need to get to a better place in measurement on this. We need more precision, is what it came down to. And the former census director, I'm sad to say, Rob Santos, who's a wonderful person, just recently stepped down, convened a fantastic group of advocates and experts from different agencies and a number of us who are working on this issue in a public meeting. And we really talked openly about this issue of how we are measuring disability and what the Census Bureau could do. And it became very clear that there is a need to call it what we mean. So what I mean by this is, when we say disability, we all mean different things. Sometimes we mean functioning. Sometimes we mean workability. But we need to get precise. When you mean functioning, say functioning. Because what we heard loud and clear from the disability community is they mean a demographic group. And what's important here is that we design and develop our data to represent the perspectives of the community we serve and not of ourselves, not how we think it should be measured. And that I credit prior Director Santos, to opening the door to conversation about. So he followed up with a great blog, and it basically said, people who are disabled want and need to be represented in the data and in the process that shapes what data are collected. People with disabilities want to be a part of that. They want to say in how disability is being measured, and that hasn't happened historically. But in addition, the concept of data as power came through very clearly in this discourse and in all the engagement with the community that came. And I think, again, that's very true today. Without data, complaints and lawsuits are the primary drivers of policy change. Those are important levers. They're inequitable, they take a long time, and not everyone can access them. Data, and when we democratize and share data with good practices, opens the door for more people to engage in the process and to have a say. And that also was a very clear message that we heard from the disability community. So as a center, we have repeatedly and now doubled down on this concept from that experience of what we call disability data justice. And that concept is, like other concepts of data justice who are familiar with it, is using data to try and redress the harms on certain populations or groups. For this, it's the disability community. That means that people with disabilities have to be part of all steps in that process, right? That makes lots of folks uncomfortable, I'll be honest. It also means that we need to use that data to make change for the population in the way that they think is best. So that process means collecting evidence. So we need to expand and improve data collection access and use to make sure more people have that access. And then use that to drive policy change, evidence-based policy change. We learned this lesson from our dashboards, and I'll talk more about that in a minute. But during COVID-19, when we propped up those dashboards, I still get emails today with stories of how advocates and individual community members use the data on those dashboards to advocate in their local or state levels for change. And then those policy changes hopefully lead to structural changes, bigger changes to prevent inequities happening in the first place. But then we need the data again for accountability. And to make sure those policies and those practices are working the way they should be, or maybe need to be expanded or changed or shifted, or society changes over time. And so, as I mentioned, we have this suite of disability data dashboards that we've now launched and are working on some more to really put what we call disability data justice in action. We have the COVID-19 one I talked about. We have one assessing how accessible it is to enroll in food stamps, supplemental nutrition assistance plan, and a great one that prior postdoc in the department, Erica Twardczak, who's now doing great things as a faculty member at Michigan, Erica Twardczak, launched on public transit systems. And so all of those follow similar principles in that we're collecting this data, we're building new data infrastructures and measures, to be honest, but then we're sharing it out and making sure it's accessible to the people who we are serving, right? So this was the part of the talk where I paused and how to best address. Normally when I give this talk, I talk about the workforce and that, it's not important to do the work, but who gets to do the work. And again, what the disability community has said is making sure disabled people are part of disability research is essential, but honestly, a part of all work has opportunity to be. But I think it's still important to say it, right? I think it's still important in this moment to talk about it. So as an individual with a disability, trying to make a career as a researcher, an academic researcher, as I alluded to, there's been more barriers than I can say in this short period of time in this conversation. Early in my career, I was facing immense barriers, and nobody seemed to be talking about the barriers that people with disabilities in academia were facing. I went to the NIH. I went to folks all over the place. And the answer was always, no one's ever brought that up before, which was shocking because the ADA passed in 1990. So I did the only thing I knew how to do, which is research. And it took a long time. And I had to actually get data through a Freedom of Information Act request to understand the percentage of NIH researchers with disabilities. And I requested that data over a decade. And what I found is the percentage declined from 2008 to 2018 from 1.9 to 1.2%. These data are collected, for those of you who are familiar, in EHR, or ERA, sorry, in the ERA Commons. It's not a required component, so there's certainly limitations to this data, which we talk about in the paper we published, but there's still a signal here. There's still a fact that either we're not asking the right questions, people are afraid to disclose, or we simply don't have the representation we should. This is nowhere near the over 0.25% of Americans with disabilities that live in our communities. It's not reflective of that percentage at all, right? We've got work to do. Further, data from the National Science Foundation mirrors that, right? There's some reproducibility. I didn't generate this data, NSF has generated this data, showing that less than, about 1%, sorry, of NSF grantees report having a disability, and that's largely been unchanged. Importantly, too, a separate data set has shown that less than 3% of the STEM workforce reports having a disability. But strikingly, it's the only group to have no change in representation over the past 10 years, no improvement. We've known these data, we haven't done anything about it. We'll see if that changes. Further, Franz Castro, who's an amazing researcher at my center, has shown that researchers with disabilities are paid less. We don't think about the pay gap, that matters for people's lives. STEM professionals with doctorates earn more than $10,000 per year less. They have a disability than when they don't. It's worse in academia, it's more than $14,000 per year. But we don't think about those things when we're talking about equity in the job. So certainly, I hope all of this underscores that it's a time for change. And what I would have shifted to is really great traction for things that were happening at NIH. And now it's sort of history. As a result of that paper that we published using the data from the Freedom of Information Act, I got an angry email from then leadership of NIH. It led to a number of conversations that eventually led to the launching of an advisory committee or a subgroup of the NIH advisory committee to tackle this problem. So I'm grateful that in the end they took it seriously. And I co-chaired the group along with Lisa Izoni, whose work I talked about, and Steve Burnett at Rochester. We met for over a year, and in December 2022, we launched a sweeping set of recommendations. Honestly, we swung for the fences. We knew we had to, go for it. To drive NIH to change the way that people with disabilities are being included in the workforce and in research. And to our surprise, it was unanimously endorsed by the advisory committee to the director. And it was followed by, also to our surprise, a paper drafted by leadership from across NIH for the first time publicly saying anything about ableism. And they wrote, there is space to address both disease-focused research and the health of people with disabilities broadly. And that's it exactly, right? We got a lot of pushback, basically saying, so what are you, this push for disability health equity, should we abandon all we're doing? And that is an oversimplification of the ask here. This quote is exactly it. We can do both, right? So as Heather also alluded to, our top ask was for people with disabilities to be designated a health disparity population. This was essential to opening funding opportunities that previously were not there, now are on the line, to address the health inequities that people with disabilities face and to support the inclusion of researchers with disabilities. Those opportunities were not there previously. So this could only be given by the director of the National Institute of Minority Health and Health Disparities, not the NIH director at large, in consultation with the director of HRQ. HRQ was on board. NIMHD was not sure. So they called an external advisory committee to consider if they should give the designation. Many of us were watching this closely. And when that external committee met, and it had to be a public forum, they, one, disclosed not a single person with a disability was on that committee. And two, they said that the designation should not be given. And their criteria for that had to do with very ableist assumptions about what disability is and isn't. So of course I was watching that. It happened on a Friday and I could not sleep, right? I thought, all right, on Monday, I'll clear my head. I made it to Saturday morning, admittedly. And so I called Tony Coelho, who is a former congressman. He serves in the House of Representatives, representing California, and actually was the drafter and initial sponsor of the ADA, the Americans with Disabilities Act. He's in his 80s now, but he's got same energy. Tony was fired up and is amazing. And he's like, we're gonna do something. So I called my colleague Jay Kennedy at Washington State University, who was also tracking this. And we decided to write, to start a letter writing campaign, right? To get signatures, urging the NIH to change course. We had no idea. It was like a Hail Mary pass, right? We had no idea if this was going to work. I've never done anything like that in my life. Didn't know what I was doing. We drafted it as quickly as we could. Tony said we had to get it in by the end of the week. We had to get all our signatures. And to our surprise, in less than 48 hours, we had almost 2,000 signatures. So we sent that to the White House. We sent it to Secretary Becerra, who was the head of HHS at the time, head of NIH, and all other parties who were involved. And then we waited. And a couple of weeks later, we got a phone call from the White House. They said, "Are you sitting down?" They said, "Get ready, because NIH is going to announce the designation." And that was amazing, right? And I share this because I don't think as public health professionals, we understand our role in advocacy. It is essential. It is essential. It is hard. And we might not all disagree, or we might not all agree. But it is essential to drive change in policy and to fight for the things that you research and the people you serve. So what can epidemiologists do, right? And I think a lot about this. I really do believe that epidemiologists have an opportunity to be the leaders in the public health space, to make public health more disability inclusive. I'm almost done, I promise. So I'm showing this great paper that I had the chance to write with Jennifer Deal, who I think is on in New England Journal, talking about why including people with disabilities in research and clinical trials is essential. It's essential for generalizability. Even when people with disabilities are enrolled in clinical studies, so often they're excluded from our data collection and our analyses. That erodes our generalizability. Us as epidemiologists have something to do with that. We can change that. Further, with one of my colleagues, Rupa Valdez at UVA, we also wrote in New England Journal about measurement. We can build measures to make change. We do that as epidemiologists. There's not currently a great measure of ableism or structural ableism even. And you can't change what you don't measure. We know that in epidemiology, right? We know that. We can change that. We must first find ways to measure ableism before we can dismantle it or address it, right? And it's not just for that, it's for any kind of concept of inequity. So I hope that from this talk, what you take away is that you do have the power to move forward and think carefully about how disability is measured and conceptualized in the work you do. Think about it carefully. You have opportunities to collect and use disability data as a demographic. That will make a big change. You also have opportunities to prioritize the accessibility of data collection, of analyses, and dissemination. Not assume that people with disabilities aren't among you, aren't doing the analyses, and also aren't part of the populations you serve. And to ensure disabled people are part of all of our work because they're part of all of our communities. And most importantly, I think, to fight for whatever it is you believe in, right? I've learned that time and time again. It is certainly nervous, a nervous thing to do, but public health is built on social justice. And we have to remember that. And we have to remember this connection between data and society. We have a responsibility. I'm not trying to say that any one way of thinking about things is right or wrong, but you have to decide what that is and fight for what you believe in. And then I'm going to end on something a colleague has given me advice a number of years ago, I think applies here. It's a concept to defend your optimism. And I think that this is a moment to do that. That is not to say you put on the rose-colored glasses and you bury your head in the sand and are toxically optimistic, I think is the quote. The idea here is that to imagine a better future takes work. It is not passive. It is absolutely active. The passive process is falling into despair. And trust me, I'm there on most days right now. But it is work to think of a better future and to try and fight for it. And I think as public health professionals, that's what we do for the people we serve. All right, and that's it. So if you do want to learn more about this work, I'll just plug, I've co-founded what's called the Disability Health Equity Research Network with Scott Landis at Syracuse, open to any. We have over 1,000 members. We meet virtually. And if you want to learn more about my center, you can go to disabilityhealth.jhu.edu. And about that time, so I'll stop there.